Over the course of the semester, I put together a presentation that I ultimately titled A Comprehensive Outline of Concussion Diagnosis and Management. My name is Kate Deering, and I'm looking forward to talking to you about this. Over the course of this presentation, I will cover my introduction and why I chose this project, a review of relevant literature, my updated concussion protocol for Adams State University, including pre-participation standards, concussion management documentation standards, and my new return to play protocol. I will also go over my results and recommendations and all of the new documentations and forms I made over the course of the semester. So first off, why did I choose this project? In 2014, I started as a GA at Adams State University and kind of took it on faith that there was a concussion protocol in place that met the standards of the NCAA and the NATA without really looking into it. The head AT was new the year that I started, and he told me that he had a protocol and had been using it for years, so I kind of took it on faith. It wasn't until this past winter, after I had a student athlete sustain a fairly severe concussion, that I looked into the athletic training handbook and the concussion protocol available online. They were both really old, from about 2010, 2013, that range, so it pushed me in the direction of constructing a true protocol with all of the forms needed to maintain adequate documentation of a concussion, all the way from diagnosis to management and all of the progress notes in between. So the first bit of information I'd like to cover is about the prevalence of traumatic brain injuries in the United States. So a traumatic brain injury, also abbreviated a TBI, is an incredibly common thing in the United States, with between 1.6 to 1.8 million sport-related traumatic brain injuries occurring annually. 1 out of 10 of 54 million people with disability in the United States has a related history of TBI, which really just shows that it's not getting your bell rung or a ding to the head. It's something a lot more serious. 75 to 80% of TBIs are classified as mild traumatic brain injuries, or MTBIs. Now, the term MTBI is synonymous with concussion in most cases. These symptoms can last for as long as a month in about 50% of the population and up to a year in 25% of the population. So they have some fairly long-lasting effects. A concussion can be defined as a transient disruption of brain function brought on by a direct or indirect biomechanical force acting on the brain, such as the result of a blow to the head, neck, or face, either directly or indirectly. This results in subsequent acceleration-deceleration forces being transmitted to the brain. There are two classifications of concussion. There's a coup and a contra-coup concussion. A coup concussion is brain damage at the site of the impact. So assuming a student athlete falls and hits their head on the court, the side of the brain that's damaged, so the side that hits the floor, results in a coup concussion. Assuming the same student athlete fell and their brain shifts from the side that hits over to the opposite side that's facing the ceiling, hits on that side of the skull, and then settles back, that is a contra-coup concussion, or brain damage on the opposite side of impact. So axonal shearing that occurs with a concussion disrupts the ability of the brain to transmit information and results in a change of permeability of the membrane surrounding the brain. This change makes the brain more susceptible to further injury and alters the chemical function of the brain, which results in the signs and symptoms of a concussion. Part of the reason that TBIs have gotten so much attention in recent years is the growing awareness in science behind the long-term effects of TBI and concussion. So one or more traumatic brain injuries can result in physical, cognitive, behavioral, and emotional changes. Someone that's sustained one or more TBIs is more susceptible to conditions like binge drinking, epilepsy, depression, Alzheimer's, Parkinson's, and even death over time. One TBI can result in up to a 14% loss in productivity. In 2002, Dr. Bennett Omalu was charged with completing the autopsy of former Pittsburgh Steelers player Mike Webster. He discovered a brain that resembled that of a much older man suffering from numerous different neurological diseases. Omalu eventually named the condition chronic traumatic encephalopathy, or CTE, and started to really look into the effect of repeated subconcussive forces on the brain, which just leads to a complete alteration of brain function. His research was brought to the attention of the NFL, who really resisted his findings and kind of tried to defame him and take away all of his credibility. The information and increasing awareness has resulted into further research. And at-risk populations include hockey players, wrestlers, military servicemen and women, football players, and boxers. Though in 1957, this condition was first observed in boxers and was thought to only exist in boxers. One of the most commonly used tests is a Standardized Assessment of Concussion, or SAC test. It is a non-computerized test designed to analyze the cognitive function of an individual following a blow to the head. It takes approximately 6 to 8 minutes to complete and assesses the orientation, immediate memory, concentration, and delayed recall of a student athlete. They're given a score from 0 to 30 following completion of the test, and that can be compared to their baseline in order to diagnose a concussion. In 2001, McCrae completed a study utilizing 1,325 high school and collegiate football players and used a SAC test to obtain a preseason baseline measure in order to compare it to any post-injury results. McCrae found that the SAC test was 95% sensitive and 76% specific within 48 hours of injury, meaning it's a really reliable tool for observing cognitive discrepancies between a baseline and a post-injury test, and 76% of the time will provide an accurate diagnosis of a concussion. This is a SAC test. As you can see, it's broken into 4 different categories: orientation, immediate memory, concentration, and delayed recall. So orientation just asks the student athlete about those really glaring details that they might not pick up on if they've really sustained a fairly severe blow to the head, like the month, date, day of the week, year, and the time within an hour. You grade them on a score from 0 to 5 and compare it to their baseline at the end of the test. Immediate memory, you have a list of predetermined words, so 5 words. You read the student athlete those 5 words, ask them to repeat them back to you, and repeat that process 2 more times. Then you give them a score out of 15. More often than not, a concussed student athlete won't have the attention span to repeat those words back to you, and they'll show a discrepancy between their baseline and their present post-injury score. The concentration, you have them recite the numbers backwards to you. So I would read 493 and ask them to say 394. Really makes them focus on what they're doing. Then you ask them to recite the months of the year in reverse order. And then without giving them the words, you ask them to repeat those 5 words back to you. So all in all, the scores are added together to complete one SAC test, which can then be compared to a baseline to determine the status of a student athlete. A balanced error scoring system, or BEST test, was designed to be inexpensive, highly accessible, and easily replicated in any scenario, which makes it an invaluable tool for an athletic trainer or other related healthcare professional in diagnosing a concussion. A BEST test has 6 different testing conditions, 3 on a stable surface, then repeated on an unstable surface. And these are your feet together, eyes closed, your hands rest on the tops of your hips or iliac crests for 20 seconds. Then you move to single leg, eyes closed for 20 seconds, and then tandem stance, eyes closed for 20 seconds. You repeat the 3 tests on an unstable surface like a folded up towel or a blue foam Eric's pad like in the picture. Any error is a deviation from the starting position. Opening of the eyes, hands moving off the hips, feet moving out of position, things like that. In 2009, Broglio, Zhu, Sopiars, and Park completed a study that evaluated the reliability of a BEST test in 48 young adults by determining the number of trials needed to generate a clinically acceptable, so above a 0.8 level of test-retest reliability. Each participant was administered the BEST test 5 subsequent times in one setting, and then asked to return 50 days later to complete another 5 BEST tests. The researchers, based on their results, recommended that the mean results of 3 BEST tests should be taken as the student athlete's baseline in order to increase the reliability of the BEST test following the diagnosis of a concussion in order to accommodate for the learning curve associated with taking the test multiple times. One of the more lengthy and comprehensive tools that can be used to diagnose a concussion is the Sport Concussion Assessment Tool. The third and most recent edition came out in 2013, but in 2001, the Concussion in Sport group designed the first SCAT test, and their goal was to standardize concussion assessment internationally and across all sports. So because the SCAT-3 is fairly recent, there's really not a ton of research about it, but the SCAT-2 was released in 2002 and thought to be fairly streamlined when compared to the original SCAT. Research found that it was 83% sensitive and 91% specific when a baseline wasn't available. So it was really good at diagnosing or not diagnosing, if the student athlete didn't have a concussion, the condition of the patient being examined. The components of a SCAT-3 are a Glasgow Coma Scale for more catastrophic injuries, a SAC test, Maddox questions, which assess the orientation of the student athlete, a BEST test, a graded symptoms checklist, so a scale from 0 to 6. Do you have a headache? Are you nauseous? Do you feel like you're in a fog? Things like that. And a coordination exam that really is somewhat similar to a field-based sobriety test that's conducted by law enforcement, so bringing your finger to your nose and then switching hands, that kind of thing. IMPACT stands for Immediate Post-Concussion Assessment and Cognitive Testing. It's a computerized test that's commonly used to determine a baseline and then obtain a post-injury score if the student athlete is thought to have a concussion. There are three main components. There's a section collecting demographic information about the student athlete, a series of neuropsychological tests, and a post-concussion symptom scale. So much like the SCAT-3, a graded symptom checklist. So are you experiencing headache? Do you feel like you're in a fog? Things like that. So IMPACT was developed as a means of diagnosing and monitoring the progress of an athlete with a concussion more accurately by decreasing the likelihood of experiencing a learning curve, which would lead to higher scores. The neuropsychological testing evaluates the attention span, memory, processing speed, and reaction time of a student athlete. There are 6 tests that evaluate these 4 domains. They are word memory, design memory, X's and O's, symbol matching, color matching, and 3-letter memory. These 6 tests more specifically evaluate verbal memory, visual motor speed, and reaction time. In a study, IMPACT alone was able to successfully classify 85% of cases, so concussed or non-concussed, in a study completed by Schatz et al. Utilizing 138 participants, 72 of whom were concussed and 66 of whom were not. When I started to put together my concussion protocol, I used 3 sets of guidelines from 3 separate committees or governing bodies. The first of these was the 4th International Conference on Concussion in Sport in Zurich. It took place in 2012, and it outlined 4 separate domains that may signify the presence of a concussion. These domains are a direct blow to the head, face, neck, or subsequent force translated to the brain following impact, so an indirect blow. A rapid onset of signs and symptoms, an inability to diagnose the injury without any known medical imaging, because CAT scans and MRIs do not pick up on a concussion. There is no known way of objectively diagnosing a concussion, so all concussion diagnoses are purely clinical. And the final is that symptoms gradually subside with physical and cognitive rest. So they said that symptoms could be somatic, cognitive, emotional, physical, and behavioral. And these are all recognized as indications of a concussion. Somatic symptoms are things like headache. Cognitive symptoms are things like feeling in a fog or difficulty concentrating. Emotional symptoms can include sadness and depression. And physical symptoms would be more acute and include something like a loss of consciousness. And finally, behavioral changes are evidenced in irritability. No athlete should return to play in the same day that it is assumed that they have sustained a concussion, according to these guidelines. This policy and procedure that they put together, this big consensus statement, is largely patient-centered. So the return to play was designed in a way that would optimize recovery and keep the student athletes safe, but also get them back as quickly and efficiently as possible. Committee members would only be considered for inclusion in this committee if they had no scientific or commercial interests in the outcome of the conference, practiced in the disciplines of athletic training, sport medicine, clinical science, neuroscience, neuroimaging, and sports science, and they met in a public setting in order to divulge all relevant information and engage in a discussion regarding that data. Inclusion of a systematic literature review was also included in the discussion and decision-making process, and the publication of the results of the committee were available in order to better educate relevant healthcare professionals. The most important reference that I used, at least to me, was the NATA position statement. The NATA, or National Athletic Trainers Association, is my governing body, so their guidelines are the most important to me as a professional. They made these guidelines public in 2014, and it seriously lists about 50 recommendations. These recommendations include a baseline examination and a really thorough clinical history that measures physical and neurologic evaluations, motor control, so balance testing, and neurocognitive function. The NAT also recommends that all baseline and post-injury testing are completed in a similar setting. Those are some of the biggest takeaways for me. They also said that at a minimum, you should conduct a SAC test and a BEST test together to diagnose a concussion and compare that to a baseline. The pre-participation standards that they outline should include any details about previous concussions and the associated symptoms and severity of that concussion or those concussions, and a concussion-related personal history that discloses any conditions that may impact the treatment of a concussion, such as ADHD, or a family history of migraines, ADHD, conditions like that. They also stress the importance of thorough documentation from the onset of the initial injury to the student athlete being released back without any restrictions. The NATA recommends that the athletic trainer should include the mechanism of injury, initial signs and symptoms, the state of consciousness at the time of the initial injury, the findings of any subsequent neurologic exams, so an upper quarter screening, lower quarter screening, and cranial nerve exam, which will be included later in this presentation, and physical exams, symptom evaluation sheets, neurocognitive function, and motor control, while making a note of any deficits when compared to the baseline, and the instructions that the certified athletic trainer gave the student athlete and their responsible party are all things that should be documented over the course of the student athlete's recovery. The last set of relevant guidelines that I included in my review of the literature is the guidelines for the management of sport-related concussion put out by the NCAA, or the National Collegiate Athletic Association. They, in their statement, listed physical symptoms, cognitive symptoms, emotional symptoms, and sleep-related symptoms. So physical symptoms that the NCAA listed are headache, nausea, vomiting, balance problems, fatigue, sensitivity to light, numbness or tingling, or stunned and dazed appearance. Cognitive symptoms were feeling foggy, feeling slowed down, difficulty concentrating, difficulty remembering, short-term memory loss, or answering questions more slowly. Emotional symptoms were irritability, sadness, increased emotional volatility, or nervousness out of the norm. And then one of the domains that they included that the other two didn't were sleep-related symptoms. So drowsiness, sleeping more than usual, sleeping less than usual, or difficulty falling asleep. Like the NATA position statement and the Zurich consensus statement, the NCAA recommends that a SAC test and a BEST test should be administered together following an injury to the head, neck, or face, as both a baseline and a post-injury measurement. All institutions should have an annual educational presentation for student athletes and coaches available that informs them about the signs and symptoms of a concussion, that any student athlete suffering from a suspected concussion is immediately removed from play and may not return the same day that they were diagnosed with concussion, and that medical clearance must be acquired from an appropriate medical professional. This presentation should also outline the return to play that student athletes will complete at the institution. One aspect of recovery from a concussion that's usually left out of all of the relevant literature is a return to the classroom. So decreasing cognitive stimulation when treating a concussion is just as important as decreasing the amount of physical exertion. To help with this, it's suggested that students are excused from school and classes, anything that exacerbates their symptoms. They should be given optional rest periods throughout the day when symptoms begin to return, and that lasts for as long as they are asymptomatic again. This isn't as important in college because everyone has a different class schedule, but for high school age students, this is a fairly important step. For all student athletes, they should be given an extension of pre-established deadlines on papers and assignments, as long as they can prove that they had made reasonable progress prior to the concussion. They should be excused, and there should also be a postponement of tests, something that's a really big cognitive stressor for student athletes. One more thing that should apply across all domains, they should be allowed to wear a hat and sunglasses if they're still sensitive to light. This also helps to decrease that cognitive stress. Ultimately, utilizing all of these steps will aid in speeding up their return to play by giving them rest in all aspects of their life and allowing their symptoms to subside without aggravating them. These steps can be taken through a relevant administrator, so at Adams State, it's Ken Marquez. As an athletic trainer, I can email Ken Marquez and say, this student athlete sustained a concussion on this date, and they should be excused from classes. And then that information is forwarded to all of the students' professors. Something like that should be established across the board at any institution in order to help speed the recovery of the student athlete. Now we're going to start moving into the protocol and forms that I created. So prior to participation as a student athlete at Adams State University, all potential student athletes should complete a pre-participation packet that includes information about past head injuries, including any concussions and its accompanying signs and symptoms, the time it took for that student athlete to return to play, and the severity of the signs and symptoms. This pre-participation packet will also include a family history about any relevant medical conditions that affect cognitive function, as well as any personal history of those conditions. This medical history can be included in the general medical paperwork that is administered prior to participation of the student athlete. So on the slide, I included a chart that has all the standards that should be completed prior to participation as an athlete. So the pre-participation packet, a concussion history form, which we covered, an educational PowerPoint, which the students and coaches have to watch annually, a signed waiver that details the assumption of risk and the understanding of what a concussion is, and the accompanying risks that a student athlete assumes with participation as a collegiate athlete, a baseline SAC test, which can be completed in a team setting under the athletic trainer supervision, a baseline BEST test, which has to be completed with their athletic trainer, an impact test, which may also be completed in a team setting, though the best results have been found in individual settings because that mimics any post-injury conditions that they might experience, and a baseline symptom sheet. So this will be a graded symptom checklist from 0 to 6. Do you have a concussion? Are you experiencing any headache, nausea, vomiting, any of those symptoms? All of this must be completed before the student athlete participates in any school-related practices or conditioning session. Following a concussion, there are a series of steps and documentation forms that have to be completed. So on this slide, I included a checklist that's really easy to follow that'll help the athletic trainer stay on top of that documentation. This documentation should include a SAC test and a BEST test. These can be administered together. An initial and follow-up clinical evaluation form, which is included a couple slides after this, and impact or a SCAT-3 within 24 to 48 hours of the student athlete sustaining an injury. So prior to participation, the student athlete will complete a baseline impact test or a SCAT-3, which will give the athletic trainer a baseline to compare those post-injury results with. The student athlete or a responsible party, this could be a roommate or a parent, will be provided with written home care instructions, which we'll also cover in a few slides. And then there should be a written injury report. So a SOAP note that includes the mechanism of injury, the time and date of injury, how the injury occurred, and any related signs and symptoms that happened both post-injury and when the student athlete was released into the care of a responsible party. This is the home care instruction sheet that should be given to a student athlete after they sustain a concussion. Following the completion of the practice or game that the student athlete is injured in, they will accompany their athletic trainer into the athletic training room in order to be given further instruction about what symptoms are normal, what symptoms are abnormal, when and if the student athlete should be taken to the hospital by a responsible party, and how to address their symptoms. This information should be relayed both verbally and in a written format, which would be this sheet. The instruction sheet includes a brief definition of a concussion, normal signs and symptoms, have the date that the student athlete sustained their concussion, and include instructions for their care. The student athlete should be instructed to partake in cognitive and physical rest and avoid any other overstimulating environments that exacerbate their symptoms. This means putting down their phone, staying away from televisions. Any of these things can exacerbate those symptoms. Once all of this information has been divulged, the student athlete should be instructed to return to the athletic training room the following day to complete a symptom sheet and a neurologic evaluation that examines myotones, dermatomes, cranial nerves, and if they haven't already, complete an impact test or SCAT-3. As you can see, the initial and follow-up concussion evaluation form includes general information about the student athlete, the date and the approximate time of the injury, the mechanism of the injury, whether or not they have a prior history of concussion, if so, when that last concussion was, and then information to be completed in the immediate evaluation of the student athlete. The initial evaluation should have all information about loss of consciousness filled out, whether or not the student athlete experienced any amnesia, and the findings of an upper quarter screening, lower quarter screening, and cranial nerve exam. If any abnormalities were noted in the initial evaluation, the form should be completed in its entirety until the student athlete has not experienced any abnormalities for 48 hours. Regardless of whether or not any abnormalities were observed, the student athlete should complete the graded symptom checklist daily. The following slides will contain information about an upper quarter screening, lower quarter screening, and then a cranial nerve screening. This is a form that I created that gives instructions to complete a BEST test and allows the athletic trainer to fill out a form as they complete that BEST test. So it has the name, the date of the injury, the sport of the student athlete, the time of injury, the date of the exam, the time of the exam, the mechanism of injury, any previous history of concussion, if so, when, and this can also be filled out as a baseline measure, in which case some of that information really isn't relevant. It includes instructions for the athletic trainer that can be relayed to the student athlete and makes completing a BEST test that much easier. This chart contains information about all upper extremity nerve distributions and the myotomes, so the strength of the innervation when compared bilaterally, dermatomes, the sensation of the innervation when compared bilaterally, so any numbness or tingling reported by the student athlete, and the reflexes that can be tested for each innervation. So the nerve root C4 would be the top of the shoulder and neck. So the upper trapezius, to test the myotome, you would ask them to elevate their shoulders and then resist that movement. The dermatome would just be feeling for the top of that and asking for any numbness or tingling or any other strange experiences. C5 would be shoulder abduction, so moving the arm away from the body and then holding that there against resistance. The dermatome would be just feeling that. Again, all dermatomes are just feeling those distributions. So C6 would be the lateral arm and the thumb, feeling those for any numbness or tingling, any weird sensations, and the myotome would be elbow flexion and wrist extension. So you ask the athlete to move to 90 degrees of elbow flexion and 90 degrees of wrist extension, and then you resist those movements to see if there's any weakness on one side compared to the other, or if there's weakness present on both sides. C7 is the middle finger and posterior middle arm. The myotome is elbow extension and wrist flexion. This is the same setup as C6, you just resist the opposite direction. C8 is the medial hand, you resist finger flexion. T1 is the medial elbow and you resist finger abduction and adduction. So you ask them to splay their fingers and then squeeze them together and separate to see if they can resist that. Again, any discrepancies or abnormalities should be reported by the student athlete and noted on the evaluation form. This chart contains all the information of the myotomes and dermatomes for a lower quarter screening, as well as a picture that details what areas should be felt and swept during a dermatome evaluation of both the upper and lower quarter screening. So L1, the dermatome is the anterior upper thigh and lateral hip. The myotome is hip flexion, so you would ask the athlete to sit, draw their knee up, and then you would resist that movement. L2 is the anterior mid-thigh, which would also be hip flexion, but in addition, you would test knee extension. So in that seated position, you'd have the athlete actively extend their knee with your resistance. The dermatomes for L3 are the lower anterior medial thigh, the VMO. you would again test knee extension. For L4, the dermatoma is the anterior or medial leg. You test dorsiflexion of the foot. So you can either test this by having the athlete walk on their heels and ask them to keep their forefoot and toes from hitting the ground, or in that seated position, you can have them dorsiflex actively and then resist that. L5 is also the anterior leg, but it's the lateral leg this time, so the medial leg. You would test knee flexion and great toe extension. So in that seated position, you would have them actively flex against resistance, and then you would separately ask them to pull up their great toe and then try to push that down manually. S1 is the lateral ankle for the dermatome, and the myotome is knee flexion and plantar flexion. So you would have the athlete walk on their toes, asking them to keep their heels from touching the ground, or keeping them seated in that 90-degree position. You would resist knee flexion, or you would resist plantar flexion by asking them to push against your hand like they're pushing on a gas pedal. S2, the dermatome is the posterior and superior lower leg, and there is no myotome or reflex to test this. There are 12 cranial nerves that should be tested following what is suspected to be a concussion. They're all included in this chart, along with the name of the nerve, the number of the nerve, the function, and how to assess that nerve. So cranial nerve 1 is the olfactory nerve. It tests smell. You can ask them to recognize the smell of grass or get a cup of Gatorade, see if they can identify that. Cranial nerve 2 is the optic nerve. You would test sight and their visual reaction to light. So one time at a time, you can see if their pupils are equal and reactive to light, and see if they're able to focus on items that are both near and far. Cranial nerve 3 is the oculomotor nerve. This tests eye movement. The patient should be asked to follow the examiner's finger or the pen light as it moves in a bow tie pattern. Cranial nerve 4 is the trochlear nerve. This controls inferolateral eye movement. So this can also be tested with the bow tie, described in the previous cranial nerve. Cranial nerve 5 is the trigeminal nerve. This is facial sensation. So you can ask the student athlete to clench their teeth, and you can palpate on both sides of the face, see if there are any discrepancies or any numbness and tingling present. Cranial nerve 6 is the abducens nerve. It is responsible for lateral eye movement. The patient can follow the examiner's finger as it moves in a cross pattern. You're looking for any nystagmus, which is an involuntary flickering of the eyes. Cranial nerve 7 is the facial nerve. It functions to provide the student athlete with the ability to move their face and to taste. So you can ask them to smile, frown, ask them to drink Gatorade, see if they can identify the flavor. Cranial nerve 8 is the vestibulocochlear nerve. It's responsible for hearing and balance. You can test this by rubbing your fingers next to the student athlete's ear, and you can see if they can identify which ear you're rubbing your fingers next to, and then you can complete a best test. Cranial nerve 9 is the glossopharyngeal nerve. This tests taste and tongue movements. So you can ask them to swallow, and then the same test that you used in cranial nerve 7 can be used in cranial nerve 9. So you can ask them to identify Gatorade. So if you made purple Gatorade that day, well, what flavor is that? Cranial nerve 10 is the vagus nerve. It's responsible for breathing, tasting, and swallowing. So ask them to swallow, ask them to take a deep breath. Cranial nerve 11 is the accessory nerve, and it supplies the sternocleidomastoid and trapezius function. So you can assess neck flexion and shoulder shrugs, but this is also tested in the upper quarter screening. Cranial nerve 12 is the hypoglossal nerve. It is responsible for innervating the muscles of the tongue. So you can just ask them to stick their tongue out. Any abnormalities should be noted on the evaluation form, and the student athlete should be told that without improvement in any symptoms, a visit to a neurologist should be considered. This return to play protocol was designed directly after the NCAA, NATA, and Zurich consensus statement guidelines. All three sources agreed on a single return to play protocol that I adopted for this project to be included in the Adams State University Athletic Training Handbook for future use of athletic trainers on staff. The first stage of this return to play will be 15 to 20 minutes of light cardio, such as biking or running, being sure to keep their heart rate at under 70% of their age-predicted heart rate. which can be determined by subtracting the student athlete's age from 220 and then being multiplied by 0.7, which is 70%. Stage 2 is completion of a sport-specific conditioning session and drills with their assigned athletic trainer. Some examples include, but are not limited to, a wide receiver running routes and receiving passes from their athletic trainer, a soccer player practicing breakaway goals and dribbling through cones, working on explosive movements, a softball or a baseball player receiving ground balls or pop flies, or a basketball player running full court layups with accompanying ball handling drills. The third stage will be a full-length non-contact practice with the student-athlete's team and one session of weight training that the student-athlete has missed while they were medically ineligible to compete because of their concussion. During this stage, they will participate in all team warm-ups, non-contact drills, conditioning, and will be expected to participate for the entire length of the practice. Stage 4 will be a full contact practice but no live gameplay. During this stage, the student-athlete will be allowed to practice without restrictions and should complete the entire length of the practice and all accompanying weights and conditioning sessions. The fifth and final stage will be an unrestricted return to play in a game setting. Because this environment is the highest intensity a student-athlete will be exposed to, and the members of the opposing team will not be aware of or sensitive to the student-athlete's status as a recently symptomatic concussed athlete, this stage should be the final stage before the student-athlete is released from the care of the athletic trainer. It should be noted that if at any point during the return to play the student-athlete experiences a return of symptoms, they must stop immediately. The student-athlete has to remain symptom-free for 24 hours before they can advance to the next stage of the return to play. And if any return of symptoms occurs, they will be moved back to the previous stage that they completed without a return of symptoms. As a result of all of the research and forums that I've designed, I would suggest implementing all of them at Adams State University. I would recommend continuing compliance with all NCAA, NATA, and International Conference on Concussion standards in order to utilize the highest standard of evidence-based medicine. The athletic trainers on staff should also be more rigorous in meeting the standards of these governing bodies and should improve documentation by utilizing the forms that I've created in conjunction with this project. This project and its forms make it easier for others that I work with to manage the concussions of their student athletes. All of the research that I've completed, from the review of literature to the forms and recommendations that I've given to the athletic training staff, will be available wherever I go. This makes their job easier and allows them to manage concussions in a way that meets the standards of the NCAA and the NATA. This comprehensive protocol also means that student athletes will receive the best possible care and treatment, something that will help student athletes return to play in a timely manner that also builds their confidence in their athletic trainers and the recovery process. The biggest personal benefit of having completed this project is a sense of accomplishment in having put together a comprehensive concussion management and return to play protocol. This is something that I can take with me anywhere I go as a certified athletic trainer, and I can use this knowledge and procedures to either concede that my workplace is appropriate standards or that they're outdated and I can implement my procedures. It is also amazing to be able to say that I designed and created the majority of some of the forms that have been included in this protocol. Administration has definitely been the weakest part of my practice as an athletic trainer until this semester. Because of this project, I was motivated to look at the athletic training handbook here at Adams State University and start to update all of it, including the concussion protocol and emergency action plans, with the help of my boss, the head athletic trainer. All of this is built on my ability as a certified athletic trainer and has prepared me to succeed in any setting in terms of proper documentation and the management of the concussion.